Hi, and welcome to Implementation of Enhanced Barrier Precautions in Nursing Homes to Prevent the Spread of Multi-Drug Resistant Organisms. This presentation is going to introduce you to the updated guidance for the implementation of enhanced barrier precautions in nursing homes to prevent the spread of multi-drug resistant organisms. First, some of the common terms used in CDC's guidance and recommendations. This includes multi-drug resistant organisms, or MDRO, which is a germ such as bacteria or fungus that is resistant to multiple different antimicrobials. Examples of MDROs that you may have heard about include Candida auris, MRSA, and CRE, which have been referred to in the media as nightmare bacteria. When infections develop from these germs, they can be very difficult to treat. Colonization means the germ has been found on or in the body, but is not causing any symptoms or infection. The presentation will describe the impact and the burden of MDROs in nursing homes and describe the need for enhanced barrier precautions, or EBP, as well as the details behind the indication for and the use of EBP. The presentation will also include discussions on how to be successful with the implementation and use of enhanced barrier precautions. We have learned from studies and outbreak investigations that many nursing home residents are unknowingly colonized with an MDRO, especially residents with risk factors for colonization, like indwelling medical devices or wounds. Residents who are colonized are at risk for developing a serious infection, like a bloodstream infection, and can remain colonized for long periods of time, and these germs can spread to other residents through the contaminated hands and clothing of healthcare personnel. To help visualize how common MDROs are in nursing homes, this slide shows data from a large study that was conducted in nursing homes, including a subset of nursing homes called ventilator-capable nursing homes that provide care to ventilator-dependent residents. In the first column, these are the percentage of residents who had documentation in their medical record of a presence of an MDRO colonization or infection. So about 2 out of every 10 residents across all these nursing homes were already known to have an MDRO. During the study, nursing home residents were tested to see if they were colonized with an MDRO. The second column shows the percentages of residents who actually had an MDRO after testing was complete. As you can see, in the nursing homes that did not provide ventilator care, almost 6 out of 10 residents were found to have an MDRO, and in the ventilator-capable nursing homes, the number went up to almost 8 out of every 10 residents. So if your nursing home has 100 residents, this would be the same as having 80 of those residents colonized with an MDRO. What this data, and other data like it, shows is that there are many nursing home residents who are colonized with MDROs, and we are not even aware of most of them. And the numbers are even higher in nursing homes that take care of the most complex residents, such as residents on ventilators. Historically, nursing homes have used contact precautions when caring for residents who are actively infected with an MDRO, meaning they have symptoms or might even be on antibiotics for an infection. Contact precautions require the use of gown and gloves whenever entering the room, placing the resident in a single-person room, and restricting them from all group activities. However, as we just showed with the study, the problem with MDROs is much larger, and focusing only on interventions for residents with an active infection is not sufficient. Further, contact precautions are very restrictive, especially when put in place for a significant amount of time. We also know that contact precautions can have negative consequences. There is a need for an intervention to reduce the spread of MDROs that does not require isolating residents for a long period of time, but that also considers extended duration that residents can remain colonized. Enhanced barrier precautions are a method for reducing the spread of MDROs while also reducing the isolation of residents by using a gown and glove to prevent contamination of healthcare personnel hands and clothing during activities that have demonstrated the highest risk for transfer of MDROs to the hands and clothing of healthcare personnel. Enhanced barrier precautions are indicated for nursing home residents who have an infection or known colonization with an MDRO when contact precautions do not otherwise apply. Contact precautions should still be used for the presence of acute diarrhea, draining wounds, or other sites of secretions or excretions that are unable to be covered or contained and may be used for a limited time period during the investigation of a suspected or confirmed MDRO outbreak in consultation with public health. Additionally, enhanced barrier precautions are indicated for any nursing home residents who have wounds and/or indwelling medical devices, as these are residents at increased risk of becoming colonized with an MDRO. While prior guidance focused on MDRO outbreaks, novel and targeted MDROs, and limited areas of nursing homes that were experiencing an outbreak, enhanced barrier precautions is no longer limited to outbreaks or specific MDROs and should be applied broadly for any nursing home resident that meets the criteria on this slide. Specifically, EBP includes the use of gown and gloves during high contact resident care activities, including dressing, bathing or showering, performing transfers, changing linens, providing hygiene, changing a resident's brief or assisting them with toileting, direct care of an indwelling medical device such as a central line, urinary catheter, feeding tube, or a tracheostomy, and when performing wound care on any skin opening that requires a dressing. A private room is not required for the resident needing EBP, and residents are able to participate in group activities. They are not restricted to their room. This recommendation is intended to be used for residents' entire length of stay or for those whose devices or wounds have healed or been removed, then enhanced barrier precautions may be stopped at that time. For enhanced barrier precautions to be successful, the use of EBP must be incorporated with several other good practices, including hand hygiene, environmental cleaning and disinfection, auditing of hand hygiene, and appropriate use of PPE, and communication about residents with MDROs both within your facility and outside of your facility. We strongly encourage you to look at these additional resources. The first link will take you to the guidance document, including printable versions of the document and the table within the document that compares EBP to standard and contact precautions, as well as additional information and resources for healthcare personnel and nursing home staff and residents, families, and visitors. The second link will take you to a list of frequently asked questions about EBP, and the remaining links will take you to more detailed documents that review available literature and descriptions of the use of EBP that was developed by the Healthcare Infection Control Practice Advisory Committee. Regarding enhanced barrier precautions, we're going to go over a few FAQs. Question 1. What are the differences between enhanced barrier precautions and standard precautions? As part of standard precautions which apply to the care of all residents at all times, the use of PPE is based on anticipated exposure to blood, body fluids, secretions, or excretions. For example, gloves are recommended when contact with blood or other potentially infectious material, mucous membranes, non-intact skin, or contaminated equipment could occur. A gown is recommended to protect skin and prevent soiling of clothing during procedures and activities that could cause contact with blood, body fluids, secretions, or excretions. Enhanced barrier precautions, on the other hand, expand the use of gown and gloves beyond anticipated blood and body fluid exposures. They focus on the use of gown and gloves during high contact resident care activities that have been demonstrated to result in the transfer of MDROs to hands and clothing of healthcare personnel, even if body fluid and blood exposure is not anticipated. Enhanced barrier precautions are recommended for residents known to be colonized or infected with an MDRO, as well as those at increased risk of MDRO acquisition, for example, residents with wounds or indwelling medical devices. Standard precautions still apply when using enhanced barrier precautions. For example, if splashes and sprays are anticipated during the high contact care activity, face protection should be used in addition to the gown and gloves. What are the differences between enhanced barrier precautions and contact precautions? Contact precautions require the use of gown and gloves on every entry into the resident's room, regardless of the level of care being provided to the resident. The resident is given dedicated equipment, for example, stethoscopes and blood pressure cuffs, and is placed in a private room where possible. When private rooms are not available, some residents, for example, residents with the same pathogen, may be roomed together. This is called cohorting. Residents on contact precautions are recommended to be restricted to their rooms except for medically necessary care, including restriction from participating in group activities. Contact precautions are generally intended to be time-limited and, when implemented, should include a plan for discontinuation or de-escalation. On the other hand, enhanced barrier precautions require the use of gown and gloves only for high-risk, high-contact resident care activities, unless otherwise indicated as part of standard precautions. Residents are not restricted to their rooms and do not require placement in a private room. Enhanced barrier precautions also allow residents to participate in group activities. Because enhanced barrier precautions do not impose the same activity and room placement restrictions as contact precautions, they are intended to be in place for the duration of a resident's stay in the facility or until resolution of the open wound or discontinuation of an indwelling medical device that placed them in the high-risk category to begin with. Which resident should be placed into enhanced barrier precautions? Assuming contact precautions do not otherwise apply, enhanced barrier precautions are recommended for residents with any of the following. Number 1, an infection or colonization with an MDRO, or number 2, a wound or indwelling medical device, even if the resident is not known to be infected or colonized with an MDRO. While prior iterations of the enhanced barrier precaution guidance were intended for use solely during public health response activities, enhanced barrier precautions are currently recommended to be used broadly in all units across the whole facility for residents who meet either of the above criteria. This broader application includes facilities where targeted MDROs have not yet been identified and is intended to minimize the transmission of MDROs in nursing homes. Which activities are included under the term providing hygiene? Providing hygiene refers to practices such as brushing teeth, combing hair, and shaving. Many of the high-contact resident care activities listed in the guidance are commonly bundled as part of morning and evening care for the resident, rather than occurring at multiple isolated interactions with the resident throughout the day. Combing a resident's hair that is not otherwise bundled with other high-contact resident care would not generally necessitate the use of gown and gloves under providing hygiene. The guidance advises using EBP for the care and use of indwelling medical devices. What does that mean? The safest practice would be to wear a gown and gloves for any care, for example, dressing changes, or use, such as injecting or infusing medications or tube feeds, of the indwelling medical device. It may be acceptable to use gloves alone for some uses of a medical device that involves only limited physical contact between the healthcare worker and the resident. For example, passing meds through a feeding tube, as long as the healthcare worker's clothing will not come in contact with the resident's bedding. Facilities should define these limited contact activities in policies and procedures and educate healthcare personnel to ensure consistent application of enhanced barrier precautions. What is the definition of indwelling medical device? An indwelling medical device provides a direct pathway for pathogens in the environment to enter the body and cause infection. Examples include, but are not limited to, central vascular lines, including hemodialysis catheters, indwelling urinary catheters, feeding tubes, and tracheostomy tubes. Devices that are fully embedded in the body without components that communicate with the outside, such as pacemakers, would not be considered an indication for enhanced barrier precautions. You may also ask yourself, why did the CDC expand EBP to include all residents with wounds or indwelling medical devices, regardless of an MDRO status? Indwelling medical devices and wounds are risk factors for colonization with an MDRO. Once colonized, these residents can serve as sources of transmission within the facility. The expansion of EBP for all residents with wounds or indwelling medical devices is intended to protect these high-risk individuals both from acquisition and from serving as a source of transmission if they have already become colonized. Are gowns and gloves recommended for EBP when transferring a resident from a wheelchair to a chair in the day room or dining room? In general, gowns and gloves would not be recommended when performing a simple transfer in a common area such as dining or activity room, where contact is anticipated to be shorter in duration. However, outside of the residence room, EBP should be followed when performing transfers or assisting during bathing in a shared or common shower room, and when working with residents in the therapy gym, specifically when anticipating that close physical contact while assisting with transfers and mobility. Are EBP recommended for MRSA and other MDROs? While enhanced barrier precautions were initially intended for those who were colonized with or at risk for colonization with novel or targeted MDROs, CDC's updated guidance now provides facilities and jurisdictions the flexibility to implement enhanced barrier precautions for residents who are colonized or infected with an epidemiologically important pathogen. For this reason, facilities may consider EBP for more common MDROs such as MRSA. If implemented, enhanced barrier precautions for residents with known MRSA colonization should be utilized in the same manner as enhanced barrier precautions for novel or targeted MDROs and should not replace other interventions targeting MRSA infection and transmission. Examples of MDROs that are targeted by CDC include pan-resistant organisms, carbapenemase producing carbapenem-resistant Enterobacteriales, carbapenemase producing carbapenem-resistant Pseudomonas, carbapenemase producing carbapenem-resistant Acinetobacter baumannii, and Candida auris. Additional epidemiologically important MDROs may include, but are not limited to, MRSA, ESBL-producing Enterobacters, vancomycin-resistant Enterococci, or VRE, drug-resistant Pseudomonas aeruginosa, and drug-resistant Streptococcus pneumoniae. How long should a resident remain on EBP? Enhanced barrier precautions are intended to be used for the duration of a resident's stay in a facility. A transition back to standard precautions alone might be appropriate for residents who are placed on EBP solely because of the presence of a wound or an indwelling medical device when the wound heals or the device is removed. Is physical or occupational therapy considered a high-contact resident care activity? The answer is yes. Therapists should use gowns and gloves when working with residents on enhanced barrier precautions in the therapy gym or in the resident's room if they anticipate close physical contact while assisting with transfers, mobility, or any other high-contact activity. As part of standard precautions, gowns and gloves should be removed and hand hygiene performed when moving to work with another resident. Therapists should also ensure reusable therapy equipment is cleaned and disinfected after each use, and surfaces in the therapy gym receive routine cleaning and disinfection. Should housekeeping wear gowns and gloves when cleaning and disinfecting rooms of residents on EBP? The research that was the basis for the current guidance evaluated high-contact resident care activities, not specifically the risk of transmission of MDROs to the hands or clothing of environmental services or housekeeping personnel. However, changing linen is considered a high-contact resident care activity. Gowns and gloves should be worn by EVS personnel if they are changing the linen of a resident who is on enhanced barrier precautions, and should be considered for additional environmental services or housekeeping responsibilities that involve extensive contact with the resident or the resident's environment. Gloves and gown use by EVS should be based on facility policy and for the anticipated exposure to body fluids, chemicals, or contaminated surfaces. It is important to remember that gowns and gloves should be worn by EV personnel when cleaning and disinfecting the room of residents on contact precautions. Can PPE used for EBP be thrown away in regular trash, or does it need to go in red bagged waste? The OSHA Bloodborne Pathogen Standard uses the term regulated waste to refer to the following categories of waste which require special handling at a minimum: liquid or semi-liquid blood or other potentially infectious materials, contaminated items that would release blood or other potentially infectious materials, which is also called OPIM, in a liquid or semi-liquid state if compressed. Items that are caked with dried blood or OPIM and are capable of releasing these materials during handling. Contaminated sharps, pathological and microbiological waste containing blood or OPIM. Based on this definition, most PPE used during resident care, including the care of residents placed in enhanced barrier or transmission-based precautions, would not fall into the category of regulated waste requiring disposal in a biohazard bag and could be discarded as routine, non-infectious waste. Employees need to remember to have a trash can available inside the resident room to allow for removal of PPE inside the room. As a reminder, OPIM or other potentially infectious material includes semen, vaginal secretions, cerebrospinal fluid, synovial fluid, pleural fluid, pericardial fluid, peritoneal fluid, amniotic fluid, and any body fluid that is visibly contaminated with blood. OPIM does not include sweat, tears, or saliva unless they are visibly contaminated with blood, or the exception is saliva in a dental procedure. That is the end of today's presentation. If you have additional questions regarding enhanced barrier precautions or the new guidance, please see Megan. To receive credit for completing this in-service, employees will need to complete and pass the competency exam with a score of 80% or higher. Please place your completed test paper in Megan's mailbox. Thank you and have a great day.